So, hello to everybody. Thanks to Manos and Manos for this wonderful meeting. And this is the presentation. Doesn't go? Yeah. As everyone knows, the risk factors for a bunker repair failure are bony defects, capsular tissue deficiency, shoulder hyperlaxity, and people who are involved in contact sports. Talking about the measurement of glenoid bone loss and the bipolar bone loss, right now I have to say that it's very difficult to calculate it, and there is no an objective method to calculate the exact cutoff when to do something or another thing. By the way, let's focus on the soft tissue. And right now we think that the soft tissue, capsule and subscap, are getting a very important role for the stability of the shoulder. And how I say here that the capsular stretch, I think it's, or capsular insufficiency, is one of the most important things for shoulder instability. And so we have to see in the office the patient. We have to measure the sulcus sign, that is a synonym of coracohumeral ligament laxity or elongation. Here you can see the coracohumeral ligament takes care of the shifting of the inferior, shifting of the humeral head inferiorly. And now you can see it has a band that shares with the subscap and another band that shares with the infraspinatus tendon and goes to the humerus. And the other test is the Coudan test. You do it with the arm in the adduction position. You external rotate. And if the rotation is above 85 degrees, you have an elongation of the anterior and anterior inferior capsule. This is very important. Another thing that if a guy is involved in contact sports, the percentage of redislocation are very, very high. And so there are three surgical treatments that have done the historical of the shoulder instability. Le Latarjet, that was invented in 1954 by Mr. Latarjet, and then published by Gilles Walsh in 1988. The remplissage by my friend Wolf in 2008, and myself that invented the ASA in 2010. One is a French idea, the other one is an American idea, and the last one is an Italian idea. In shoulder hyperlaxity or capsular deficiency, the subscapularis tendon, especially in its upper border, is lax and has to be lax. We must not forget that. Okay, and you see this is a non-elastic tendon that behaves like that, and this is an elastic tendon that behaves like that. And if you shift the subscap up, it carries up all the anterior inferior soft tissue. According to this idea of Lenny Johnson in 1986, who told that when you have no ligaments, you should involve the subscapularis tendon, I thought about that, and in about 15 years later, I thought about that, using his idea, modifying with using the upper third of the subscap and fix it with a new generation anchor, not like he does with staples that were not good. These are the anchors, and this is the technique. You have to do a capsular repair. Even if the tissue is not good, you have to try, or a bunker repair, and then augment with the upper third of the subscap. Then in the video that I present next, you will see more accurately the technique. It's a very simple technique. You have to do the steps in a right way, but if you do it, it's 20 minutes and you have done. And you address the problem from in front. I present, I'm the honor to present at the Harvard Medical School in 2015 the technique, and these are the considerations. We believe that ASA procedure reduces the coracohumeral ligament length and reduces the capsular volume. This is a study that we done with ultra MRI pre and post, and we see that there is accordingly 20% of reduction of the capsular volume and reduction of the coracohumeral length. We did a biomechanical study with the German friends, and we realized that there is a reduction of anterior-inferior translation more than the bunker repair. This is another study that my friend Raffaele Russo did, and the consideration is, and the conclusion is that the recurrence rate of ASA plus bunker repair is equal as the one to the Latarjet when the indications are good. Sorry. In considerations, the ASA acts on the opposite side of the Latarjet. This is before the operation, you say no capsule, and after the operation. This is on front, this is on behind. The heel sacs before the operation and after the operation, and the humeral head, as you see, shift posteriorly. So you recenter the head. We found that there is no osteoarthritis, a mild osteoarthritis, very like the Latarjet or other kind of surgery. So there is no arthritis. Follow-up. I know that Manos and Manos tested the strength of the subscap after the surgery, and they realized that there is no decrease of subscapulary strength. So we should not be afraid to use this the subscapularis any longer. These are the indication. And so ASA bunker repair represent an effective option where the Latarjet is an overtreatment. Like this case, this is an 18 years old patient, and I think that this surgery could be avoided. As all you can see. The ASA has a triple effect. Address the stretched part of the subscapularis, restore the capsular insufficiency, restore the coracohumeral ligament tension, so it will work without causing external rotation restriction. This is something that to remember the last meeting.
So I actually had a comment. You had a good session this morning. That can explain your operation and why it works, and answer Roshan Wade's question as well. So part of instability is the shoulder comes out anterior inferior, but you tear the rotator interval, and your subscapularis upper border becomes lax because it drops away. The coracohumeral ligament stretches out and has a band that attaches to the subscapularis in addition to the supraspinatus. So when you do your Bankart repair, and you repair all of the capsule and you tighten that, there's always capsular stretching and capsular insufficiency. Some of that is posterior, and that's addressed by the remplissage, and some of that is anterior, which means that the upper subscap has to be lax. It has to be stretched out. And if you tenodese it laterally or medially, if you repair it back to the supraspinatus, you both combat that stretching of the upper subscap, restore your capsular insufficiency, and restore the coracohumeral ligament tension. So it should work without causing a problem. So what you're doing makes perfect sense. I think your results are excellent, and you should not see, as long as you limit it to the upper subscap, then you have two advantages, not just the fact that you're tightening the subscapularis, but also that you're shortening the more medial band of the coracohumeral ligament and thereby restoring better stability of the shoulder, including the posterior inferior component. That's why it works, and it works very well. So you should be congratulated. It's a nice operation.
That's what Buddy said. You don't limit the external rotation when a guy is hyperexternal rotating, you put it into normal when you do this surgery. So it's not a putty plot, as Buddy said, because the putty plot was dealing with the entire tendon, and this is not a putty plot. And we did a multi-center study, and we had, when we see that the shoulder external rotation is not compromised, and we have 4% of dislocation on more than, the patient were 397 patients. So 4 reasons to do this surgery: low learning curve, low recurrence rate, low complication rate, high opportunity for new surgery. As I showed this case. This case was operated 3 years after, had a dislocation. See the scar tissue on the upper side of the joint with after the tenodesis. You can, if the subscap is good, this is a bunker repair that failed, and you redo it again. And there is no problem. This is a guy result of 5 months post-op. Can go to sports without any problem. This guy had 5 dislocations before surgery. And this for me is very important because my friend Pietro Randelli wrote an editorial commentary about the technique, and I am very glad he did it. And I want to thank him for his time to analyze the technique. And this technique is they're doing in China. This is a result, a paper that they wrote about the technique. My friend Zhang wrote this chapter, and I will be a guest, the guest presentation in the next San Francisco ANA to show the technique to the US. And these are the countries where this technique is used, so it's expanding, and I hope it will expand more. And it's an Italian idea, and and it's a good idea, I think. And I will have to thank my Greek friends that they showed the results at the last ASA, and they said that ASA is a safe and effective procedure augmenting the bunker repair, leading to satisfactory results to mid-term outcomes, with obviously with the subcritical glenoid bone loss. This is to remember the last meeting in Athens, and thank you very much.